On today's podcast.
So chronobiology, so this is kind of crazy. If we eat late at night, so our microbes actually are attuned to light and dark. This is wild.
Whoa.
Our gut. So if we are eating out of our natural time to be eating, that's going to make us gain even more weight, have more inflammation, influence leptin and insulin sensitivity and everything. And that has to do with our microbiome as well, because they're up eating instead of sleeping.
If you're a healthcare provider tired of just treating symptoms and ready to dig deeper into the root causes of health issues, the Vibrant Wellness Podcast is for you. With insider tips, expert interviews, and the latest in biotech research, this podcast will take your patient care to the next level. Welcome back to the Vibrant Wellness Podcast. I'm Jen Rivas. I am so honored to be here along with my partner in crime, Dr. Emmy Brown. Today, we have a special guest who is not just any doctor, she is a modern medicine maverick. Introducing Dr. Sarah Zielsdorf, or as many fondly call her, Dr. Z. She's not only a board-certified internist and microbiologist, but also the dynamic medical director at Motivated Medicine, which, by the way, I love that name. What makes her stand out? Dr. Z's she knows the struggle firsthand. She's lived with an autoimmune thyroid condition and chronic illness. She has walked the path that many of her patients have tread. Her mission to be a true partner in healing with, what so many seek. So with a unique approach that's data-driven, grounded in science, and always evolving, Dr. Z and her team are on a relentless quest to uncover the root causes of health conditions. And guess what? She is here to share her journey, her insights, and her passion for medicine with us today. So let's give her a warm welcome. Thank you for coming to the podcast, Dr. Z.
Thank you so much for having me.
Of course.
We're so happy you're here, Dr. Z. And I'm really excited to talk about, even from childhood, it sounds like you were really interested in medicine and microbiology. So it sounds like you felt that calling from a young age, which resonates with me because I remember saying I wanted to perform surgery and I was probably 5 at most. And you mentioned in one of your interviews, you told your parents, you freaked out your parents, and you said you wanted to hunt Ebola after reading all about it.
Yeah.
And I just love that you were fascinated at such a young age. And I'd love to know more. What really inspired you to go into microbiology, and how did that lead to you becoming the physician you are today?
Well, first it was medicine. I was born as a preemie. I was born over 6 weeks early. And I actually had a pretty significant birth defect. It's where the esophagus and trachea are joined together. It's called a tracheoesophageal fistula. So I spent my first month or more than a month in the hospital. I had really significant surgery, and I spent a lot of time as a little kid getting checkups, and I had to have actually pretty significant procedures. And at that time, they didn't really anesthetize babies or children. They just kind of held kids down and did it. It wasn't until I think 1987 that our experts in anesthesiology actually said, "Hey, babies feel pain, and you need to actually um,
Jeez.
give proper medication." We don't even think about that. But even in my generation, things were very different as kids, and so I got to meet the surgeon who operated on me when I was about 4, and that was a woman. And so from that time, it was like that was it. I really wanted to be a surgeon and a doctor, and all of that changed. And then in middle school, I got into reading. At that time, the Hot Zone was very popular, and there was a movie in the 90s called a little bit later called Outbreak. With Dustin Hoffman and Renee Russo and Morgan Freeman, and that what just like was one of those things that I was like, I that's what I want to do. And I started really getting into learning about what EIS officers do for the CDC, which these are officers that crisscross the globe. They're usually doctors, and they deal with pandemics and with zoonotic disease and new transmission of new diseases. And so that's really how it started. Middle school, high school, and from then on, it was okay. I'm going to be a microbiologist, And so I got my undergrad at Miami University in microbiology and went on to do a master's in public health. It was a really cool program at GW George Washington, which was a split program between microbiology and public health. And so you took half the classes in the School of Medicine and half public health. And I got to study with really important figures who deal with epidemiology and dealt with infections. But I got sick on the way of my goal. I went to medical school. I had been diagnosed as hypothyroid in college. And that's a bigger part. I kind of muscled through that, thought that it was just your thyroid, took the medicine they gave me only to get progressively sicker as I went through my training. And so the first part was that I always wanted to be a doctor. The second part was my interest got piqued. And my microbiology background really, how smart and how amazing the study of microbiology is. I just never get tired learning of it. And in the process of doing what I did to help myself, really started to understand that so much of our health depends on our own personal microbiomes and that intersection and influence of our microbes on our immune system, and on the interface between what makes us human and our microbiome, and even bigger than that, the interactions of the microbial world and the human world, and that's just evolved from there.
Mhm. Thank you for sharing that. I know we're going to dive deep into microbiology, but I first want to ask you about a term I saw on your website that really intrigued me, and I'd love for you to kind of share with the audience what you mean by this. But you use translational medicine. Can you describe that for us?
So it's really challenging because a lot of people want to label me. They're like, oh, she's a functional medicine doctor. And the problem is that term isn't so respected in allopathic medicine. And when I'm trying to work with my allopathic friends, the first thing that I want them to know is, hey, I'm a board certified internist. That's what I do. I just happen to have a bigger, broader education that leads me to looking at patients and their stories and really looking at root cause medicine. But especially for chronic illness patients where they don't have one diagnosis that equals that symptom that can be treated with a pill. And we do a really crummy job of that in allopathic medicine. We're awesome for focused problem-based medicine or trauma. Like if you break your arm, you go to the ER, you get x-rayed, yep, it's broken. And then you have a consultant in orthopedics that is able to specifically help if it's needed. That's amazing. That's really amazing. And the problem is the patients that I see have not been able to been helped by that approach.
Mhm.
What I talk about in and what I really prefer to be called that, is that translational medicine is a type of personalized approach. It's personalized and it's precise medicine. But what it is the translation, literally, the translation of everything that is happening right now in our medical literature, the stuff that's coming out right now, and actually utilizing that and influencing how we actually practice, so-called from the bench to the bedside. And so the average physician and the average practice, just in general, when we're in medical school, we're about 17 years behind what actually is in the literature.
Mm.
And so when we talk about evidence-based medicine, one of the best quotes was from my professor in medical school, and he was one of the deans of medicine. He became dean of medicine, and uh, he said 50% of what you learn in medical school is incorrect. You just don't know what 50% that is.
Oh, wow.
Yeah, that actually, instead it was supposed to make me feel better about freaking
Yeah.
out about exams, but it actually made everything far worse.
Yeah.
And so my approach is also one of great humility. I see I see again our knowledge as being so frankly pitiful compared to what's out there. Think about when I talk about microbiome analysis, no matter what I use, and Vibrance Test, the gut tumor that I do use is probably the most advanced of what's one of the most that's out there as far as the tests that are about on par with each other. Um, but it is such a tiny fraction of what actually is in there. We haven't characterized so much of bacterial world, let alone fungi or parasites or viruses or any of these other things in our world. It's just woefully inadequate. But I really strive to be current and to be doing what I can to help people based on what's actually being done and what's actually being researched.
Yeah, absolutely. And I want to pull on that thread in terms of the gut microbiome a little bit, Dr. Z. And because the implications of GI health have reached this wellness industry is booming. Functional medicine practitioners, of course, are hyper focus on the gut microbiome. And I've heard you say that we are more microbe than human. And so I'm wondering, what do you think are the most important implications of that concept?
Well, what's really interesting is I don't ascribe to say that we are literally what makes us human is more microbial. That's not true. It's more of a tongue in cheek comment about just genetic expression. As far as significant human genes, we've got about 20,000 exosomal genes that we think are really significant. And those things are being modified all the time. And what's so interesting is our microbiome is actually affecting human gene expression, both from what's being DNA that's actually, microbial information that's being shared between our genes and microbial genes. Some can be shared, not all. Um, Information that is influencing our health and just this interface between our microbiomes, what is synthesized. For instance, I really love measuring beta glucoronidase levels, which is an enzyme that we can talk about. But that is an enzyme that we humans make that actually influences our estrogenome, or our microbes that affect our estrogen levels and actually the composition of estrogen metabolites, and how that can influence health or disease too, both in women and in men. And I use to measure that. So, for instance, there is an enzyme, there are bacteria that secrete that enzyme that mimic our own body's enzyme. So, if it's having the same net effect, is that us as human, or is that us, the microbe, really responsible for it? When we're talking about reproductive cancers, for instance, or things like colon cancer or pancreatic cancer, which also have influence, anything that has an estrogen receptor. So when I talk about this, I also do talk about the sheer genomic effect. I was doing some research. They looked at 3,500 DNA samples of human microbiome, and they found nearly 46 million bacterial genes, 24 million in the mouth microbiome, and 22 or more in the gut microbiome. And these, if they actually take that, half of all genes in that sample were individual specific, meaning unique genes. So it means that we all have this unique
Hmm.
world in us that really is influencing us. So we talk about that. So for instance, people that have more Firmicutes, Bacteroides, they're more likely to gain weight, and I always talk about them. I'm like saying it's not really, you that's influencing that, or people who have low acromansia, for instance, less lean body mass. These are very finite things that are, they're not super sophisticated. They've been around for a decade or more. But when I was doing my master's degree in microbiology, I will tell you this: Akkermansia that we talk about all the time, Eubacterium wasn't even elucidated. We talk about that. That's in a probiotic that's on sale now. They've been talking about that influencing longevity. The species that we talk about all the time in the wellness sphere, and even in regular medicine, um, some of that wasn't even known, 15 to 20 years ago. So imagine what we'll know in 5 years or 10 years. And one of my dreams is that, acupuncturists who do herbal medicine often have the ability to mix their own powders, and they mix their own tinctures. And I see a day where we're able to get a sample of how the microbiome's been disturbed and restore it at a personal level. And that doesn't have to be just so. Again, the future really was FMT, which was fecal microbiota transplant, but it's been really fraught with, most of it, number one, was shut down because of COVID. It's not covered by insurance, and there's not a guarantee. So, like, if you're a chronic illness patient and you go, do this, one of the only covered reasons is for recurrent C. diff. So we need other ways of restoring the gut.
And I'm wondering, Dr. Z, what do you imagine? Do you imagine that will be an oral route of supplement or medication? Or, I mean, do you think that the fecal transplant is the way forward? It just needs to be, have broader indication, or
So
what do you
I think mixed. I think it depends on the indication and it depends on the person. We've seen such good results for some people who were so sick and could not get a foothold of C. diff, even with all the medications and probiotics in the world. And they really turned around with FMT, with stool transplant. And I think there'll be a place for that. But it's really interesting. They actually have, there are people that have done this, which is autologous a stool transplant. So that basically you get your gut really, really healthy. And then you actually use your own sample. They, freeze them or whatever, but then basically inoculate yourself in case you get sick.
Huh.
Wow.
Planning
So,
ahead.
so
Yeah, that's
there's people that are doing that.
wild.
But I think there's going to be a whole host of things that come out. The issue that I struggle with is, and I know this is crazy as a microbiologist, is actually probiotics. How useful are the probiotics that we take? And for
Yeah.
some people, no matter what you give, oh, this is a great probiotic, it doesn't really do anything for them. And
Mhm.
most of the probiotics that we take, well, number one, most of what's on the market doesn't really work because it's not acid resistant, or when it has to be refrigerated, it doesn't get where it needs to go and doesn't affect what needs to be done. Or it could actually be worse for someone. So one thing that gives me nightmares is there have been studies that show if you give really broad spectrum antibiotics after, say, a GI infection, that you can cause more inflammation and you can actually disturb things worse. And so you want to be very, just, very, very intentional on what you're going to give and why. But most of the time, the probiotics that we take, even those that are really good, that really have good benefits, they are affecting our immune system. They're immune modulating, but they're not actually giving those probiotics in the gut and that's going to stay there. It's not really, they're not colonizing so much.
Right.
And so this is really an interest for me. I'm really interested as to know, in the future how we can restore the system and how we can affect the most change that's not temporary.
Hmm. I have to ask the question, Dr. Z, because I am someone who is completely overwhelmed when it comes to the whole pre and probiotics that are out there. Do you have a particular brand or brands that you highly recommend?
Well, prebiotics, I really say food, prebiotic fibers, anything that helps increase short chain fatty acids, so butyrate. So I'm a huge fan of butyrate supplementation if a patient has an indication and they can't get those resistant starches. So, for instance, some of my patients who have lost oral tolerance and they really struggle to be able to tolerate food. I mean,
Mm.
I've had patients down to 2 or 3 foods, and then I've checked them and they're sensitive to those too. I mean,
Oh.
they literally have no oral tolerance left, and break that down. I mean, it's significant. So I really like um a lot of those functional foods. I like sun fiber, for instance. It's really safe for SIBO patients. I like Phyto Pre, which comes from their citrus bioflavonoids and pomegranate. There's, if I'm saying specific names, lots of different companies. I like Phytopre, I think is by Ortho Molecular. Sun Fiber is Tomorrow's Nutrition. Of course, I have to talk about spore-based probiotics. Microbiome Labs has been on the forefront, and they have some good strains we're looking at for anxiety and for other things. Zymogen, I've used some of their line as well. I use a lot of Saccharomyces boulardii in patients that don't have S or VCA antibodies. That's important to check if you're going to use it. It's really good for diarrheal infection. I actually use it. I have people take it instead, for traveler's diarrhea. And then I use a lot of immunoglobulins. I'm going to talk about that. I use a lot of serum bovine immunoglobulins, and like if somebody has an alpha gal allergy, like they had a tick bite and now they're allergic to meat, we can use goat milk colostrum. There's specific, they have that in capsular form, but really trying to get immunoglobulins in the system to bind up antibodies and really help to heal that overwhelm. Uh, I use a lot of that, and I have been dabbling in some of the other probiotics like Akkermansia, but I really, I use a lot of polyphenols to feed Akkermansia. I use ferments where people can tolerate fermented food, and I use a lot of root veggies. Have a person, like, if I have to take a person off of gluten, I'm going to tell them to eat a different color of root veggie every single day. Make
Mm.
hashes, do different colors. It's really getting all of the variety that we can. And like I said, increasing that resistant starches. So for instance, if you're team white rice and you like white rice, I have a person cook, cool, and reheat that rice, and it has concentrated resistant starch in it, which will feed that good microbiome.
Gotcha.
And also,
That's
it's about the
helpful.
timing of our food too. So chronobiology. So this is kind of crazy. If we eat late at night, so our microbes actually are attuned to light and dark. This is wild.
Mm.
Whoa.
Our gut. So if we are eating out of our natural time to be eating, that's going to make us gain even more weight, have more inflammation, influence leptin and insulin sensitivity and everything. And that has to do with our microbiome as well. because they're up eating instead of sleeping.
Huh. So crazy. Kind of like the circadian rhythm, right? It's all tied
So
together.
yep, cortisol and melatonin
Yeah.
are opposite, right? So when we go to sleep, our cortisol is supposed to be at its lowest. Our melatonin is supposed to be at its highest. That's why artificial light at night is so deadly to us. It's
Yeah.
screwing up so many things.
Get off those cell phones.
You just
Stop
covered
scrolling.
so much right
Yeah.
there, Dr. Z.
Well, I know we're going to dig even deeper, but I want to just take a little bit of a left turn because I know that you believe in the power of referring out and using other specialists. So, and even amongst your own team, you have an arsenal of different specialties there, which is fabulous. I'm wondering if I'm someone who's just starting out, or maybe a practitioner that hasn't really built a team, maybe you could guide them. How did you go about bridging these relationships? Do you have a Rolodex of people you just call on? Is it happenstance or, how did you connect with these people?
I honestly say it's still a really big work in progress. I'll have a few different people it's all word of mouth. Patients, that have seen good people. I say, who is that? Who is open minded and reaching out? So, for instance, I work with a sports medicine doc who is really interested in helping women with osteoporosis, for instance, and helping them, get better testing. So, for instance, both of us have noticed that the DEXA scan really isn't accurate for some patients. I'm not saying all, but for instance, if someone has an injury to the back and there's a lot, as one of my patients did this week, a lot of inflammation last week. This has a lot of inflammation right where they test that lumbar spine of a DEXA scan. And then her hip, was okay. And so her hip looked okay, a little bit of loss of bone density, but the back looked terrible. So much so that the doctor would threaten her and say she needs a bisphosphonate. Well, I was able to refer to my friend, and he did a really unique dynamic test that's been validated in Europe. And so it's the first place that has it in America, which is cool. In general, Europe is ahead of us. They're ahead of us 10 years ahead of us as far as what they do. I mean, that's just how it is. But anyway, he tested her and showed that sure enough, the hip and the spine were about the same and was very reassuring. And that could actually test a fragility score that the DEXA didn't give me that. And so I'm able to say, okay, I don't have to be as worried. And no, I don't have to, I can reassure her to say that she doesn't need to be threatened to take this other medicine that
Yeah.
has a significant side effect profile that she shouldn't be on if we don't absolutely need it. And being able to adequately, talk about risks and benefits. But to answer the question, I have a small team and I still, I don't have my go to, for instance, nutritionist. That's tough because in the functional sphere, most nutritionists are selling tests and selling supplements and things. And
Mhm.
if I want someone to be coached or have, very specific nutritional advice, it's kind of hard. It's really hard. Um, but yeah, as far as other clinicians, I'm always on the lookout for other open-minded clinicians to send my patients to. That's
Yeah.
that's tough. I don't have a veritable Rolodex, but I have, a burgeoning small group of people and people, throughout the country that I have referred and they've referred to me to.
Mhm.
Yep.
Great.
Okay. And Dr. Z, you just gave us a great case in terms of looking at a more, I would say, maybe probably more sensitive and specific test for bone density. But is there another case that is maybe at the top of your list for favorites in terms of bridging the gap between research now and the clinical practice?
So, I mean, I had a patient who was having symptoms and was kind of brushed off by her OB-GYN, and this was years ago. This was years ago, and I really didn't like that she was maybe having a little, I can't remember if it was, I think she'd had breakthrough bleeding or something, and she was a menopausal woman. And they kind of brushed her off.
Mhm.
Um, and and usually it's like, no, when that happens, they do an ultrasound and they, really look at everything. I had gotten a Dutch test, a dried urine test for comprehensive hormones, which a lot of people do not like. Like a lot of people will say it's even real, I mean, really smart people. It's not accurate, it's not this, it's not that. But as someone who's done, thousands of these tests, I use it to look at their metabolites, how they process estrogen and how they process things and how they methylate and looking to give me clues as to how I should treat them. Not that there's any one perfect test. That's another big takeaway I want to say. We are so, and I just, like I said, it's humbling. I feel like we're babies with regard to our ability to diagnose and treat. But I said, no, I don't like that. And I went ahead and did the ultrasound and everything. And sure enough, she ended up having stage 1 endometrial cancer. And I had a very high index of suspicion. And very rarely is stage 1 diagnosed. I mean, she only required only required a hysterectomy and no further treatment, which is, I mean, tremendous because uterine cancer is usually found later.
Yeah. Wow. Must have been very glad to to have
Yeah.
seen you.
Yeah,
Gotta
but
stay
then,
open-minded.
so then just to keep continuing that case, then I said, all right, how are we going to keep you from getting cancer? What are all of the variables in your case that are making you pro cancer? Because we all have cancer all the time, and we all have autoimmunity all the time, but our immune system keeps those things in check. And that's kind of food for thought there.
Yeah. I'm curious because we also like to ask providers occasionally about their intake process. Another thing I noticed on your website that I thought was unique was you first have sort of a discovery call to see who within your team is the best one for them to speak to. Is there anything that you feel like about your intake process, and we can talk a little bit more about that call, that you feel is unique? I know it's so important. There's a quote on your website that I loved. It said, "We're the ones putting the puzzle together, but you're the one helping lay out the pieces." So, what is it about that intake that's so important to you, and if you feel like anything is unique compared to maybe some other providers?
First of all, it's not perfect, and I really want to put that out there. The challenge is for both doctors and patients that usually it's kind of an open mishmash, like you call a scheduler or you go online and you read about the doctor and then you make an appointment. And there's no, because I have a fee for service practice because I spend a lot of time with my patients. I was part of a practice where I did my model of medicine, and I took insurance too. And it was getting to the point where I just could not get reimbursed for the time that I spent with my patients. And and everyone's always like, well, why? And that's just how it is. I spend an hour and a half with my for my first visit. And the other thing is, people are always like, in order to monetize your business, they're like, well, someone else, you can outsource that first visit. You can have another person do that. And I say, no, I can't. Listening to that person's story, there's some alchemy. There's something that I can't replicate in when I hear that person's story. And another doctor who was really this was at one of my training, he said, this is really interesting. He did this exercise. Sometimes, and I do this in my head, but when he couldn't figure out what was going on with the patient, he would literally be like, "Excuse me," and he would go outside, he would put a different coat on, and he would come in as a different doctor, and he would say, "Could you please explain that to me again?" Sometimes when I get lost, I say, "Please remind me of that history." So, for instance, sometimes there'll be a change of care within the practice, or I'll consult on a patient, and it's really challenging that I didn't do that first, and I didn't get all of that information myself. There's a doctor from the olden days named William Osler, and he was the founder of the American residency system. So I don't like that guy, but he was brilliant. And he said back in something like 1918, he said, listen to the patient will tell you the diagnosis. And that really is true. It's all, most of the time. And so that's what's really important. Now, our intake process has changed a lot. Like, it keeps changing. We have a jot form where interested patients basically answer very specific questions. What are the things that you're hoping to accomplish? Who have you seen for this? Anything specific and pertinent. And that helps us really triage the patient. So if unfortunately I have a wait list, so if it's something emergent, we have to tell them, I can't see you right this second, or this isn't appropriate for acute care. Um, someone's pregnant or whatever and needs something right this second. No, I can't get them in to do that, or it might not be appropriate to do. But that's number one, is figuring out, just, are they an appropriate patient for the practice?
Mhm.
And two, what clinician would best serve them? So I've trained, the trained clinicians that I work with as well, but all of us are different, and who would be best served by that? So I think that it's not where I want it, actually. I would love to have even more work be done to be able to ensure that patients are having the best experience.
Yeah, and I want to switch gears. I know we're jumping around a little bit, Dr. Z, but going back to stool testing, and you mentioned a very interesting strain of E. coli that was news to me in terms of its probiotic benefits. So we're going to jump into that, and the history is really fascinating. But before we do that, in a well-managed patient, are you monitoring them in terms of stool testing? Or are you saying, okay, there's no indication for this? I'm just curious in terms of screening stool tests. Are you doing those?
Yes, the answer is all of the above. Number one, it really depends on how a patient's doing. Um, I think I have set the standard as in if you're going to be one of my patients, I really want you to commit to doing comprehensive testing of your hormones and your microbiome because we can affect so much change there. Some of my patients, especially those that have been grandfathered in from old practice or those who really are, struggling or, financially or other things, because a lot of these tests are not covered by insurance, or, there's challenging. Sometimes, I work with them where they're at. But in a perfect world, we test them and then we'll retest them, say, a year out after doing different, after working to change their health in a very structured way. And I'll retest them. And from there, it's kind of, patient preference. I don't do it yearly or mandatory every 6 months. It really depends on the person and what I'm testing. Especially like, for instance, toxic burden testing. I'll test that pre and post treatment, Um, but it also is really patient dependent. There's no standard of what I do.
Sure. Yeah, that's
I
fair.
should really preface that. There's no one way I do things. There's still, right and wrong as far as a standard of care, or in my case, wanting to exceed the standard.
Of course, it's just not one size fits all.
Correct.
Yeah. Okay. So, and just looking at like picking up a beta glucuronidase, I think if a patient wanted to do a stool test to be proactive, that might be interesting in terms of history of a hormonally mediated cancer. And you touched on that, and you put that in such easy to understand terms. I think a lot of practitioners are aware of that enzyme, but it's such a nice benefit of that test and to really illustrate the global use of stool testing. So,
But
uh,
I don't know any OBs really local, regular OBs that use it, you know?
right.
I don't really, if it's so important and so well known, why isn't it accepted is the bigger question.
Yeah, absolutely. Well, and can we impact it too? I think that there's some research gaps. I've seen some disagreement in terms of calcium D-glucarate, getting that level down. I'm curious kind of what you think about that.
I mean, I've seen I the proof is in the pudding. I mean, the proof is how our patients do. And so these aren't murine models, these aren't mouse, these aren't rat, these aren't rabbit, these are human. So the patients that I see, if we give them DIM and I3C and calcium D-glucarate, some of them notice such a difference clinically for dysmenorrhea, heavy periods, regularity of periods. I've had patients who were hemorrhaging and who were able to, for the right patient, like I said, it's not everybody that's going to need that thing. But for the right patient where you've tested them and you say, okay, you're a candidate for this and getting the right dose, right product, they've done fantastic. I also see using, for instance, DIM, even calcium glucarate for men and working on getting their estrogen levels for those that aromatize.
Yeah,
So
awesome.
I've had great luck. And in others, it's saying, okay, that's not enough or that's not working for you. We need to do something else.
Sure. Yeah. Really can see the interconnection there. Okay, so I want to get into this particular bug that we do measure on the gut zoomer, and you pointed it out. And so I started to look into it, and that's the E. coli strain Nissel 1917.
Yeah.
And there's research behind it, not just for GI conditions like Crohn's and chronic constipation and IBS, but also extraintestinal conditions like UTIs and allergies.
Yeah.
I mean, real quick, the history, as I said, really interesting. So named after Professor Alfred Nissel.
Yeah, and
Um,
he didn't name it after the soldier he got the sample from, you know?
right. Yes, and please, on that note, if you want to speak to how it came about, because yeah,
So,
you're totally right.
I think that it's obvious that I'm a huge nerd, and, I really like reading about this stuff,
I
and
love it.
so 1917 wasn't a great year. Um, we were embroiled in World War I, and Germany didn't do so hot. So, Germany was losing the war. Germany got blamed for the war. And so if you take yourself to 1917 Germany, these beleaguered soldiers were coming home, and they had been through trench warfare. They had been starved. They had been probably causing gas attacks, but in gas warfare. And we had pandemic flu. We had a bunch of stuff going down. And in Liesl's hometown, this soldier came back and he was great. And they was like, how did you come back unscathed? So he did what any microbiologist, would do and say, okay, let me have a stool sample. And so he was able to isolate from this young World War I soldier's fecal sample a bacillus, a bacterium that impaired and actually killed other dysentery causing bacteria. And so for somebody that, where millions of people died of dysentery in World War I, this was pretty astounding. And so he purified it and it became the first probiotic. So E. coli strain Niesel, 1917, became known as Mutaflor, or in German Mutaflor, and it was produced in Poland. And so the other really interesting nerdy thing about it was that a young man who had some serious grievances also had stomach aches, and a doctor treated his stomach ache successfully. And so when that young man came into power, he remembered that guy, and that guy who gave him Mutaflor became his personal physician. And that was Adolf Hitler, who was treated with Mutaflor. So it cured his stomach aches. And that's how that doctor actually got his job. And so nothing against Mutaflor. I use Mutaflor. The issue is, because it's an E. coli strain, there is a lot of reticence to use it in the United States. In fact, the FDA does not allow it to be sold here. And so that makes using it more challenging. And I struggle with the FDA for many of their decisions. We need protection in this country, but we need specialists who are involved in those realms to be making those decisions. So specifically microbiologists. Now, Mutaflor, the significance of Mutaflor is that it is used from a GI perspective. It is used as a standard of care to maintain remission for ulcerative colitis in Europe. So remember that European conversation I'm having. And we've got excellent data on that. They've got it for other diarrheal conditions, and as you touched on, non-diarrheal ones. So what I think is really important is that I use a ton of different tests, and I always am trying out new tests. But what I really like about using a wheat zoomer and a gut zoomer, because a wheat zoomer will test for antibodies against lipopolysaccharide, which is a sugar that's on gram-negative bacteria, which causes systemic immune system activation and inflammation. And is really, there's a ton of research on LPS, but not a lot to show that people are making antibodies against this and having, this reaction kind of on steroids and having an autoimmune mediated reaction. And people aren't learning about it. But for Mutaflor, what's so exciting about it is I use the tests where I'm actually going to use the data to affect change. So I can measure beta glucuronidase levels. I can measure E. coli strain Niesel levels and LPS and other E. coli's. So for instance, you'll see this relationship where you have very high Enterobacteriaceae, which is the group of gram-negative bacteria that E. coli live in. And that is very inflammatory when they're overgrowing. And then you'll see very low levels of E. coli strain Niesel. So of that fraction of E. coli, you've got more dysbiotic ones. Or even I've had cases where I have pathogenic E. coli. So enteropathogenic E. coli or enterotoxigenic or enterohemorrhagic. Crazy. Like, these are things that I studied as a microbiologist that most doctors don't get into the weeds about. But toxin producing E. coli, and they can carry these. How are you going to treat it? They would have likely had a Z-Pak or other things for different illnesses, and it's still there. So you can't really treat those effectively with antibiotics for the most part, and we need new tools. And so I like to bind up the toxin, and I also like to crowd out. And so this E. coli strain is what we call a competitive inhibitor. And so I really enjoy learning about that. And, I don't have a lot of colleagues that do this, but it's a clinical interest. And so I don't just willy nilly give someone Mutaflor, nor do I give it forever. Number one, it has to be shipped cold. And so in Chicagoland, that's not the summer. So I'll do it, and I'll do it fall through winter for a patient, for instance, 3 months, 3 months, to see if I can affect some change. But I'm not going to do it if a patient is just, if I just feel like giving it. I want to test to see if they really need it. Maybe they weren't born with that good strength. That's only one example. I was just looking at a patient who had elevated levels of Acinetobacter, which is actually often a nosocomial bug, something that people get from hospitalization. And that's a really nasty one. In the soldiers from Iraq and Afghanistan were getting, especially Afghanistan, they were getting really bad Acinetobacter baumannii infections. This was around 2003 to 2005 when our soldiers were in Afghanistan. They were coming back with really significant um, really resistant infections. And so there's all this data now, this research that's going on. And I was reading one, looking at a patient with these overgrowths and saying, all right, let me just look it up with her here, saying, all right, does Mutaflor work on that? And they're showing in animal models, yeah, it does. And so we just need to keep going and get this, we need this information. I'll give you one other example. I have a patient with Clostridial overgrowths who has ulcerative colitis, and nothing worked. Literally could not tolerate meds. Mesalamine didn't work. Nothing worked. She bled constantly for 9 years.
Mm,
I put her on low-dose naltrexone because I do a lot of LDN
sure.
for immune modulation. Didn't really work on its own. And I did do Mutaflor and I did do some other stuff. And I got her better for a while because I treated one bug. And then she had a reaction to almonds or something else that she ate and started bleeding again, and we could not get it under control. She actually asked me, she said, hey, there are some patients that are using vancomycin. And I said, like we treat recalcitrant C. diff? She said, yeah. And I said, okay, let me look at your gut test again. And she has elevated levels of Clostridium.
Hmm.
And so on that basis, I said, let's try it. Oral vancomycin is not absorbed. It's not going to affect the other microbes. It kind of goes through. And she's been in remission for 6 months
Mm,
because I took a chance.
After years of
Yeah,
struggling.
years.
Wow.
And I mean, she literally told me today, she said, and she had to get a blood transfusion. She was down to, I think, 6 point something on her hemoglobin. And yeah, she's tired, a mom. I mean, she needed blood. She needed iron. She needed iron transfusion. Excuse me.
Gosh.
Um, and I mean, this is really serious. And she said to me today, she's like, I would do anything to 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 stay well. I would do anything, you know.
mm,
So I'm super passionate about this, but I don't really know anyone that does this kind of medicine at this level of minutia, and also having this both intellectual curiosity and willingness to do things as long as it's not going to cause harm,
Yeah.
you
Well
know?
yeah.
put. I don't either. Really, it's amazing.
Well, I know we're getting close to wrapping up, and it's
That
apparent
happened.
that yeah, I know,
It
right? It
zoomed
it goes
by.
by so fast. We could talk forever, for hours. But it's very apparent. You definitely have your finger on the pulse. I can tell you love research. You eat that up. What is it that you're excited about right now, Dr. Z? Any new trainings, books, events that you're interested in?
Well, I teach pharmacists. I'm going to be teaching on infertility in 2 weeks in Houston at for compounding pharmacists. It's a group known as PCCA. So if you get anything compounded and then that pharmacy is a PCCA member, they're getting their clean fillers and the bases to make all of those medicines. Like if you're on bioidentical hormones, I'm really interested in advocacy. I was in DC advocating for maintaining access to compounded hormones. Those
Mhm.
are on the chopping block, by the way. I was the only physician among a delegation of 85 pharmacists. And they were all like, why are you here? This isn't going to affect you. And I'm like, hello, I'm a woman.
Yeah.
Um, I don't want them to take that away from me. And also I take compounded thyroid medicine and I require that for my life. I have Hashimoto's. And so it wasn't diagnosed appropriately. And so I think, I am I'm all over the place. I'm researching everything. I'm really interested in just the future, and I'm interested in other people who are smarter than I am, doing cutting edge things that I can learn from them, and affect change. I work. I am the volunteer director, medical and education director for the LDN Research Trust. I do a lot of advocacy for access to low dose naltrexone. I wrote the guidelines to use it, and I just updated those for 2024. That's all volunteer. I always gnash my teeth and pull my hair out doing this, and I'm always running behind, and
Yeah.
but I'm really passionate about that. And patients that can't come to see me are able to bring those guides to their doctor, and hopefully then get the evidence to be able to and be able to advocate for themselves. Say, can I please try this? And a
Yeah.
lot of people, it's really cool because people will go online and say, hey, I use this guide and my doctor in Canada gave it to me. And I'm like, awesome.
I
That's,
love that.
I'm able to touch and reach thousands of people compared to what I can do in my own practice.
Amazing. The ripple effect. I love it.
So inspiring, Dr. Z. And I wish we could keep going. I do say that often, but I really do wish we could unpack more. And we covered so much in this short period of time. You're clearly extremely brilliant and humble. So thank you for giving us all this insight. We talked about translational medicine and microbiology and clinical practice. Before we say goodbye, will you answer our 3 rapid fire questions so we can get to know you more personally?
Okay.
I like that. Okay. Yes.
Yeah. Okay,
I
let's
think
do
you're the first one, Jen.
it. Yes. I'm curious, Dr. Z, what is the worst advice you've ever received?
Just one?
One that immediately comes to mind.
You're not meant to be a doctor.
That is, I definitely would say number 1 for you.
Yeah. They were clearly wrong. Clearly wrong. So,
Jeez.
yes, I would agree. That's the worst advice you've ever received.
Okay, next one. What are your top 3 vacation spots?
That I've been or want to be
Let's
going
say
to.
where you've been.
Probably Germany, Italy.
She's reaching deep into the memory banks here.
If they're that good, we can stop at 2.
No, it's so funny. It's like, oh, I had fun there, but that was really almost deadly. So that might not have been as good,
Well, you wanted a hot Ebola, so.
Yeah, that's true. That's true. That's true. I'd say, I'd probably say going out west. Like we went out to like Yellowstone and
Cool.
all those areas and going through the mountains. I'm from Ohio, so when like a Midwesterner goes to the mountains, it's like absolutely like experiencing God. And then you go, but why am I from Ohio? Like it's like at the same time, I feel like I got, like, oh my God, I grew up where I grew up. Why, and I live in the Midwest. Why can't I be in the mountains?
Yeah. I grew up in the Midwest, Chicagoland. So yeah, very,
Oh.
very flat for those who don't know about those flat states. So yes, mountains are they're amazing.
Third question.
All right. Last question. Something that might shock people about you.
A boring person. I
would argue differently.
that I am a bass player, and so I play the bass guitar, and I am super passionate about music. And one of the things that I love is like pretty hardcore like bands like Rammstein. I was in the fire zone of the front row of a concert screaming in German.
Wow.
That's
Don't look
awesome.
like I'm 4'11", but that's what I love.
See, that's definitely something shocking. That's awesome. Thank you so much for being here, Dr. Z. I definitely want our listeners to know where they can find you. So if you don't mind sharing your website or maybe access to the guide that you were speaking of.
So it's motivatedmedicine.com. And that's my practice. And then the other big plug that I would say you can get the guides is ldnresearchtrust.org. L as in lamb, D as in dog, N as in Nancy, and then researchtrust.org.
Awesome. We'll make sure we have that in the show notes for our listeners so they can always access that. But thank you for your time. Thank you for what you do, your dedication, your passion, and we hope to have you back sometime soon.
It was super fun. Thanks for having me.
All right. Until next time, everybody, stay vibrant. Thank you so much for being here today. Don't forget to leave us a review and subscribe so we can continue to pay it forward together. And remember, the key to longevity is knowledge. Keep learning, growing, and tuning in to the Vibrant Wellness podcast to discover the latest insights and strategies for optimal health. Join us again next week. Just a reminder, this podcast is for educational and informational purposes and is not a substitute for professional medical advice, diagnosis, or treatment. The views expressed by guest and host are their own and do not necessarily reflect the official policy of Vibrant Wellness. As always, consult your healthcare provider before applying any recommendations that you heard here today.